to have as our guest today Dr. Sanikommu and Dr. Santos from the University of Miami's brain tumor program, and they're going to discuss their recent publication in the Journal of Neuro-Oncology entitled Patient-Reported Outcomes as Prognostic Indicators for Overall Survival and PFS in Brain Tumor Patients. And for the synchronous viewers of this program, I'd remind you all, if you have questions for the authors and the team, please type them into the chat function and we'll do our best to get to those at the end of the presentation. And with that said, take it away.
Thanks, Dr. Sifrelli. Before starting my presentation, I really want to thank Dr. Sheehan, Dr. Sifrelli, and Dr. Shepard for giving this opportunity to showcase our work.
Sai, for some reason the slides are not showing.
Just give me a moment. I will try to. Can you guys see it now?
That looks great. Thank you.
First of all, thanks for the opportunity to share our work. I don't have any disclosures on this work. As we know in the regular neurosurgery, neuro-oncology trials, most traditionally the imaging findings and the molecular profilings are the ones which we use to assess the patient outcomes, like how they are doing, how the treatment works, and for the prognosis, like overall survival and progression-free survival. Over the years, Rano has created different criteria to assess the treatment assessment among neuro-oncology patients. Starting from 1990, 11 criteria, then McDonald criteria, Rano 1, Rano 2. Since 2023, there are several updates to the Rano criteria where most of them are based on the imaging findings. These are the different Rano criteria released over the years, mostly giving importance to the imaging findings. But although there is a standardized methodology for radiographic response and progression, it always not even if the imaging looks stable, we also have to take care of how the patient's actually feeling when the treatment was done. For the first time, so how we gonna assess these responses, like how they are feeling? We should have something as a quality measure. For the first time in 1984, measuring of quality of life in cancer patients was first done by Dr. Schipper. Later, it was modified in 1986, then 1993. And for the first time in 1996, a standardized tool was introduced by European organization for treatment, for research and treatment in cancer, which is aortic QLQ-C30. And then later it was particularly for brain tumor patients, BN20 was introduced. These are the different scales among QLQ-C30 and BN20. But as these scales are introduced, most of the clinical trials use them as their primary endpoints. But for the first time, using these scales as the prognostic factors was started by Mayer et al. In 2007. Later, it was done in several studies, but most of the clinical trials in neuro-oncology never used these scales to assess prognosis in brain tumor patients. We want to see how, whether these scales are really useful to assess the prognosis in clinical trial patients, particularly in neuro-oncology. There are several studies which show some of them showing there is a really independent correlation between these factors and the survival outcomes, and some showing there is no overall effect. So we want to pull this data and see if there is really these scales are really important in clinical trials. As most of the clinical trials are using this as the primary endpoints, why should we not include these scales for the prognosis? So we did a systematic review, and we found there are 8 clinical trials comprising of 6,846 patients assessing these factors. I want to first particularly mention a study by Koumans et al. From Europe, where it summarized 15 individual clinical trials in Europe and published the data in 2019 in European Journal of Cancer. These are the different scales where assessing overall survival using QLQ-C30, which shows a significant association between baseline functioning scales and overall survival. The first figure, the top figure is about the cognitive function, and the second one is about the physical functioning, which shows a significant relationship in assessing overall survival. Social functioning doesn't show any kind of association in predicting overall survival, but when we use all the when we pull all the functioning scales, it showed a significant association in assessing the overall survival. Interestingly, where BN20 scale, which was introduced for assessing the neuro-oncology patients, there isn't showed any association in significant association in predicting overall survival. When it comes to progression-free survival, QLQ-C30 also showed a significant association, both in physical functioning and also when we pulled all the functioning scales. So our take-home message was that PIOs are usually most of the clinical trials nowadays, both in several cancers and also in neuro-oncology trials, were using these as endpoints. Why should not we use these as markers to assess survival outcomes like overall survival and progression-free survival? The trials should also make sure to have systematically collect the PROs, not just randomly collecting from the patient or patient attendings, but from actually the patients, how they are feeling or something like that, and also to standardize these outcomes so that we can use them for the prognostic models. I want to thank Dr. Comator and Dr. Victor Luo and Dr. Santos for mentoring me on this project. Yeah, that's a project.
Well, thank you very much, Dr. Santos. Did you want to jump in and offer any insight into what we went over so far?
Well, I have to say congratulations to Dr. Sanikommu, that being a research student all the way from India, working with us in Miami, he just took over the idea and run with it. It was his initial own idea, and with our help, he managed to get everything done. I would just add that indeed it's very important to add patient-reported outcomes to assess prognosis with these patients with cancer. The data clearly stated it will be good in the future to try to implement it more thoroughly in future trials.
So I'll start off. I think, this is my interactions always with the C30 and the BN20 is it seems to be the sticking point in getting our clinical trials open, and it's always invariably a BN20 form is not filled out that holds us from enrolling a patient in or something like that. I wanted to get a feeling from you guys as to what the practicality you think it is to incorporate this into regular practice, because it's one thing to set a baseline, and these are designed to really help do a post hoc analysis and stratifying patients based upon their baseline studies and follow them over time. Really, all the trials that we do care about two things, OS and PFS, and these give us some more subtleties into what their quality of life may be. But Are these good tools to try to incorporate into a clinic, or do you think we can pull good parts out of them and maybe use them in our intake forms on patients who might not be on a trial?
Yeah, I mean, it's particularly the physical functioning and the cognitive functioning is like showed really significant associations. Of course, yeah, most of the skills are particularly the single item skills like a fatigue or a bladder control. Some these skills are like as I go through the different clinical trials, nothing showed a significant association in predicting overall survival or progression-free survival. But some of the skills like cognitive function, particularly which also assess the brain function and also physical functioning when we are giving more of the chemotherapy or radiotherapy, which directly affects the patient. And also like if they are doing well with the brain health, they definitely, I think there is a good chance of using them as a predictors, like early predictors, but not entirely as based on them. Maybe combined with the radiographic and molecular diagnosis.
Also, it would be important to say that Q30 and BN20 are not entirely the same. BN20 is really symptoms burden, which is clinically important, but not really robustly prognostic, I would say, compared to Q30 that actually really assess the global functional reserve of the patient, how he's really doing, how he's really feeling. I guess the combination of both, in a way, can help a lot in the future.
I think this was a great study, and I think there's much work that can be launched from this study as you presented it. And I think so. One of the things that I was intrigued about is why cognitive and why physical function are why do you think that they may be strong predictors of survival? As compared to other symptoms that are symptom-based, quality of life domains that maybe have been shown to be predictors. We oftentimes talk about things like KPS, which doesn't completely translate to cognitive and physical function. I mean, it does some, but not completely. But can you speculate, either of you, about the value and the relevance of these cognitive and physical function domains as being found to be strong predictors of overall survival, obviously in the neuro-oncological patient population?
I would say because like these factors, particularly cognitive function, which is directly linked to the brain functioning, and also physical functioning, when we are like particularly giving the patients a real hard doses of chemotherapy and also radiotherapy or even surgical. I think they directly affect the brain, and also if there is a growth, like a regrowth or something, which like before the initial scans, which we do after the surgery, I think these are the factors which will really predict. And also these, even if the patients are not able to directly tell you how they are feeling, sometimes even the KPS, which we assess like this is a subjective factor. Sometimes we feel how they are actually feeling. I think that might be the reason why these are more significantly significantly predicting the overall survival.
And do you think that these factors, may be adding some additional dimensions to our assessments of patients beyond the standard, biomarkers, molecular markers, and radiographic findings that we oftentimes track so much in neuro-oncology, that these cognitive and physical functions are really capturing aspects of the disease burden or the overall disease journey that we're missing with these other types of standardized, more traditional assessment tools that we make?
Yeah, I mean, that's a debatable, I think, because like as we see, like these are the pooling of the clinical trials. I really wish some study like particularly in the clinical trials, they really focus on this one, because these are the additional materials for a clinical trial till now. But I really hope they took it seriously, like when they're doing like next clinical trials, so that we really have a good information, so that we can strongly say, yes, these are the factors, particularly maybe the physical functioning or the cognitive functioning. We can definitely say these most of the patients we can assess that these are, if something wrong with the physical functioning or the cognitive functioning, yeah, there is something bad happening with the patient.
So Miami is an outstanding medical school and health system. Dr. Santos, what is your current practice for assessing neuro-oncological patients outside of a trial? Are you integrating PROs into your assessments and longitudinally of patients?
Well, interestingly, at the moment I'm more in a functional and epilepsy fellowship. I do like neuro-oncology, and I've done research on that on my training in Germany. So I can speak more of the German practice on that end, where we did indeed take into consideration to an extent PRO for patients, but not as thoroughly as we wish. I actually do think that in the future, it could also help us to kind of select patients in a way where maybe the patients that are not doing very well at all may not profit from a gross total resection and maybe profit more for a biopsy, compared to other patients that we think maybe it's not that resectable, but they're doing very, very well. Functionally, you can maybe try more of an aggressive resection. There's even a very interesting paper that just came out with a multi-center study with a German group that saw that patients that have a really good baseline, regardless of age, they tend to do better with gross resection compared to the other ones. So it might be good for the future in that sense as well.
Great points. Thank you both, Sai and Dr. Santos.
Thank you very much.
Matt, anything from you?
Yeah, no, this kind of dovetails nice. I mean, this was a lot of the stuff that we work on here at Allegheny, in some ways, looking at different kind of non-biologic biomarkers for prognostication. I think one of the things that a lot of our surgical oncology colleagues have found and have published heavily on in high-profile studies is that there is a benefit of doing like prehab for a lot of patients who have the benefit of time of undergoing neoadjuvant chemotherapy prior to undergoing a major, resection of a pancreatic tumor or cholangiocarcinoma in certain instances. We don't have that luxury of doing that for most patients with high-grade gliomas, right? But so the question I think comes down to is, how are these modifiable factors at all? Have you come across anything that says, hey, look, if you identify someone at initial diagnosis who has maybe mild cognitive impairment, or there is some minor changes in their baseline physical functioning, can we modify that so that, and are these patients salvageable? Meaning, can they be brought back, and can these findings be translated not just to prognostic markers, but things that you can actually modify to improve their oncologic trajectory thereafter?
So thank you very much for the question, Dr. Shepard. So you mean that how can we actively impact and modify this factor to increase the chances of a better outcome postoperatively?
Yeah, because at the end of the
question.
day, otherwise it's just another it's just another prognostic marker, right? And I think you're
Right.
We can use these things to kind of risk stratify and talk to and counsel patients. But ideally, right, when we kind of find anything, it'd be interesting if we lived in a world where we could actually implement some type of strategy that then actually allows these people to bounce back a little bit better or tolerate their ongoing treatments, thereafter. So I'm sure, I don't know if you've come across anything through your own, or if you guys are doing anything at Miami, or if there's any of these other studies have commented on that, or what, and similarly, if Dr. Sheehan and Dr. Cifarelli have any other thoughts about how to implement that. I think that'd be an interesting way to move the field forward in a slightly different direction than what we normally anticipate.
Definitely. Yeah, I entirely agree with you on that end. I do wonder, as you said, for those patients with pancreatic cancers that do go through rehab before any other type of treatment, I wonder how feasible that would be in an neuro-oncological patient, I guess time is of the essence in these patients. I personally don't know how we can really modify, besides the general modifiable risk factors that don't help the brain, like smoking and stuff like that, but like really psychologically, what can we do to improve that? I would throw the question back to you. What in your experience is something that might help?
I don't know. I wish I had their answer. Otherwise, no. But it's funny because I mean, I've been talking to a lot of our geriatrics because here in Pittsburgh we have a lot of very older. We have a very older patient population. We're the second oldest county in the nation, and so a lot of our high grade glioma patients come from the geriatric population, and so we're trying to identify strategies, and so it's more of a brainstorming session because I think your article really highlights the fact that hey, there's a lot of things that are not found on an MRI, that are not on a biomarker that you can test and do genetic screening for it, but these cognitive and physical domains have profound implications for how people do after surgery and while they're undergoing cytotoxic chemotherapy and radiation. So I thought it was really timely. Literally, we had this conversation just the other day with our geriatrics folks. So I think integrating some of those other subspecialties is what we're trying to do in our clinics. I don't know if it will make a difference or not.
But given that you have one of the biggest centers in the nation treating geriatric patients, and you said that you had the time to discuss with them, is there anything that they mentioned or that kind of will help them out, or that it's an interesting point? I just wouldn't really know. Talking with them, have you been able to gain any insight?
I think it's an iterative process right now. I think we're trying to honestly. I think we're all kind of strategizing on this, but I think it speaks to a bigger task in the oncologic community about how to maybe tackle some of these other difficult patients. Not everyone comes in with clinical trial patients. Oftentimes are selected to be not these patients who have physical limitations or significant cognitive limitations, but how do we take care of everyone else? Right. So I think your paper is really, at least if it's more of a comment, I think it's something that we could certainly look forward to more in the future. And certainly, I think it's so congratulations on working on this important topic.
Thank you very much. Very kind of you.
I think this is a great, incredibly hot, meaningful topic. Matt, to your point, we are integrating more and more things like not just palliative care, but support groups for patients and caregivers that integrate more holistic care. And we have a new contemplative medicine center at the University of Virginia that we are just beginning to try to integrate some programs into our neuro-oncology practice as well. So I think this is so meaningful. Dr. Santos, thank you so much. This is exactly the kind of work that I hope that you and others who will be watching this webinar will take to heart and really explore more. And let's, I think this is very fitting quote at the end that you have up here. It's been up here for the conversation, but we really do know that patients need for us to do better. They need to know that we care, and their families as well. And I think listening to what they are reporting through these PROs is just one step in that direction and can make a huge difference. So thank you so much. We try to keep these webinars short and very direct, engaging conversations. So we'll hopefully have you back with a future build on this work, but we'll conclude this Tumor Talk today. And thank you so much for all that you presented, and looking forward to having you back at a future point with a new contribution. So thanks.
Thank you very much, everybody.
Thanks,
and again,
Thank you all
for the opportunity.
congratulations to Dr. Sanikommu.